so let's get started. Hypersensitivity is a very, very high-yield topic for your board exams. It requires understanding of the details of immunological mechanisms and integrating your knowledge of microbiology, pathology, and clinical presentations. So I'm going to do my best to give you a brief overview. Now, hypersensitivity essentially implies that the body is overly sensitive to some type of antigen to the point of harming itself. Now, there are 4 types of hypersensitivity reactions. Types 1, 2, and 3 are antibody-mediated, while type 4 is cell-mediated. You can remember them with the mnemonic A, B, C, D. A for type 1 will help you recall both anaphylactic and atopic responses. B for type 2 will remind you of the antibodies involved in the mechanism. C for type 3 should remind you of complexes, meaning immune complexes. And D for type 4 should help you remember that it's delayed. Now let's discuss each type and some examples. Now, atopy and anaphylaxis are classic examples of type 1 hypersensitivity reactions. This occurs in 2 phases. Type 1 hypersensitivity occurs after B cells have been exposed to an antigen and class switch to synthesizing IgE. Upon second exposure to antigen, IgE antibodies on the surface of mast cells bind to the antigen and cross-linking occurs, as shown in this image. Now, this cross-linking triggers immediate degranulation and release of histamine, bradykinin, and other vasoactive amines. Now, tryptase is also released, which is a marker of mast cell activation. In the later phase of type 1 hypersensitivity, which occurs hours later, the mast cells release chemokines and other mediators, and this leads to the signs and symptoms of inflammation and tissue damage. Now, this should make sense. On the last slide, we just talked about histamine release, and now we're talking about leukotrienes, and these help to mediate some of the cardinal signs of inflammation, which are what? The cardinal signs of inflammation, you're right if you said, are rubor, calor, tumor, dolor, and functionalacia, or redness, warmth, swelling, pain, and loss of function. Now, this is a good time to review some pathology concepts. Now, anyway, type 1 hypersensitivity, since it's number 1, is the first type of hypersensitivity, and it's fast, like anaphylaxis. Now, if you've witnessed an anaphylactic reaction, or have had the misfortune to have had one yourself, a bee sting or foods like peanuts or shellfish, you know just how fast it can occur. Now, other examples of type 1 hypersensitivity include allergic asthma and drug allergies. Now, we can test for type 1 hypersensitivity reactions with a skin test or a blood test for allergen-specific IgE. Now, type 2 hypersensitivity is antibody-mediated by 3 mechanisms. In all cases, there are antibodies on our cells binding to antigens on the surface of abnormal cells, and it can lead to cell destruction, inflammation, or cell dysfunction. Now, let's talk about cell destruction first. When a foreign cell comes along with all its surface antigens, that cell gets coated or opsonized by a bunch of antibodies. So let's say you're at a friend's birthday party, and someone who didn't get invited for whatever reason gets really jealous. And that person shows up and attempts to destroy the birthday cake. What likely happens next? Well, that person is going to get surrounded by all of the birthday boy or girl's true friends, and it's going to face some consequences. That person is the foreign cell, and those real friends are antibodies protecting the birthday celebrant. So now that the foreign cell is surrounded or coated by antibodies, or opsonized, however you want to see it, 2 things can happen. First, it can lead to either just phagocytosis or phagocytosis and activation of complement. Now, another way it could go is killing by natural killer cells, and this mechanism is known as antibody-dependent cellular cytotoxicity, sometimes abbreviated ADCC. Let's talk about a few clinical examples. Now, the first is autoimmune hemolytic anemia. This can be chronic or acute, but what happens is that the red blood cells agglutinate, There's a warm and cold version, and the warm version is often due to IgG antibodies that are reacting with antigens on the red blood cell surface. For the cold version, they are typically IgM antibodies. Now, here's an image of what the red blood cells look like when they agglutinate. The next pathology is immune thrombocytopenia. What happens is that there are anti-GP2B 3A antibodies, and splenic macrophages just go ahead and phagocytose the platelets. What should you see on lab findings? Well, you're right if you said you'd see an increased number of megakaryocytes on bone marrow biopsy, since they'll be churning away trying to make more platelets. And of course, you'll see a decreased platelet count. Now, other examples include transfusion reactions and hemolytic disease of the newborn. Now, since we're talking about labs and agglutination, it's a good time to discuss the Coombs test. Now, in the direct Coombs test, it's looking for antibodies that are attached directly to the surface of red blood cells. In the indirect Coombs test, we're looking for antibodies that are in the serum, but they aren't bound to anything. Why is that important? It means that if an antigen did present, then the antibodies that are present will make that reaction happen. Now, here's a visual of what I just said. See, in the direct Coombs test, there are antibodies on the patient's red blood cells already. How are we going to detect those antibodies? Well, we need to add another antibody, so these things in blue. If there's a positive result, which means the cells agglutinate, then it means that the blue antibodies bound to the antibodies that were found directly on the patient's RBC surface, and everything clumped together. If there's a negative result, then those blue antibodies didn't find any antibodies on the patient's RBC surface to bind to, so nothing will bind. Now, in the indirect Coombs test, we're looking for antibodies that are floating around in the patient's serum, not necessarily bound to red blood cells. That's why it's indirect. So same deal. How do we detect those antibodies? We have to add other antibodies to find them, and we have to add some donor blood so that we can see agglutination. Now, again, a positive result means that the antibodies we put in found the antibodies they were looking for to bind to in the patient's serum, and it caused the red blood cells to agglutinate. If they didn't find anything, then nothing clumps, and it's a negative result. Well, now that we've discussed the mechanism of cellular destruction with phagocytosis, complement and natural killer cells, let's move on to the second mechanism for type 2 hypersensitivity, which is inflammation. As we've discussed for type 2, antibodies bind to cell surfaces, and there can be activation of the complement system. But in this mechanism, there will also be inflammation, and that is mediated by the Fc receptor. Remember that the Fc region, as shown in this image, is the constant region of the antibody, made up of a carboxy terminal with carbohydrate side chains, and this determines the antibody isotype and mediates complement and macrophage binding. Now, examples of type 2 hypersensitivity due to inflammation include Goodpasture syndrome, rheumatic fever, and hyperacute transplant rejection. In Goodpasture syndrome, there can be hematuria and hemoptysis due to antibodies to the glomerular basement membrane and alveolar basement membrane. Do you remember what type of glomerulonephritis it's associated with? You're right if you said rapidly progressive or crescentic glomerulonephritis. Can you identify what the red arrow is pointing at in this image? It is an enlarged macrophage with an ovoid, wavy, rod-like nucleus. You're right if you said it's a Nitschkow cell, and it's within this granuloma with giant cells, which the blue arrows are pointing to, called an Aschoff body. And these are characteristic of rheumatic heart diseases, which can result from rheumatic fever from group A strep. Now, there are antibodies to M protein that are cross-reacting with self-antigens. Now, in this last image, we can see thrombosis of graft vessels, which the arrows are pointing to within the glomerulus. This is due to a pre-existing recipient antibodies that are reacting to donor antigen in a hyperacute transplant rejection. Finally, the third mechanism for type 2 hypersensitivity is cellular dysfunction. When antibodies bind to cell surface receptors, there is an abnormal blockade or activation of a downstream process. I know this sounds very technical, but when you think of something getting blocked downstream, it's like something isn't receiving a signal. What usually receives a signal? You're right if you said a receptor. What are some diseases you can recall that involved something against a receptor? Well, what about myasthenia gravis? There's something wrong with acetylcholine in this disease, and how come? It's because there's an autoantibody, an anti-acetylcholine receptor 1. What else can you think of? Do these images help? Here we see exophthalmos and scalloping of the colloid. This is Graves' disease, which is because of autoantibodies that are anti-TSH receptor. Now, what about this image? Here there are some flaccid intraepidermal bullae that gets caused by acantholysis or separation of the keratinocytes. This is pemphigus vulgaris, and it's because there are IgG antibodies against desmoglein, part of the desmosomes. Now, next we can finally move on to type 3 hypersensitivity. Type 3 hypersensitivity involves immune complexes. They're made up of antigens and antibodies, mostly IgG, which activate complement and attract neutrophils. The neutrophils release lysosomal enzymes, and as you can see in this image, they can damage endothelial cells. So it makes sense that this can be associated with vasculitis and systemic manifestations. Now, for a mnemonic, you can remember that there are 3 things stuck together in a type 3 reaction: antigen, antibody, and complement. Now here we have 3 examples of diseases related to type 3 hypersensitivity. The first is SLE, or systemic lupus erythematosus. Organ damage, such as nephritis, is primarily due to a type 3 hypersensitivity reaction with decreased clearance of the immune complexes. And in this case, we're talking about the anti-DNA ones. In this first image, we see a classic malar rash in SLE. In the second image, we see a lot of renal microaneurysms pointed out by the arrows due to polyarteritis nodosa, which is one of the vasculitides that usually occurs in middle-aged men and has an association with hepatitis B. Now, these 2 images in the second row are showing enlarged and hypercellular glomeruli under light microscopy and a granular, lumpy bumpy appearance under immunofluorescence for post-streptococcal glomerulonephritis. Now, serum sickness is the prototypic immune complex disease. Serum sickness happens when a foreign protein gets introduced into your system and antibodies get formed against it. What usually happens is 1 to 2 weeks after you get exposed, antibodies are developed and they form complexes with the foreign antigen and deposit in your tissues. And this leads to complement activation and inflammation and tissue damage. So after exposure, a patient will present with fever, urticaria, arthralgia, proteinuria, and lymphadenopathy as the complexes form and build up. Now, reactions similar to serum sickness are associated with some drugs and infections. Another type 3 hypersensitivity is the Arthus reaction. This is a more local, subacute, immune complex mediated reaction. Now, when you do an intradermal injection of an antigen into a pre-sensitized individual, which means they've already been exposed and they have the circulating IgG antibodies to that antigen, then there can be the formation of immune complexes in the skin between the antigen and antibodies. This is characterized by edema, necrosis, and the activation of complement. Now, finally, we have come to type 4 hypersensitivity, the only cell-mediated reaction. Type 4 hypersensitivity has 2 mechanisms, and they both involve T cells. The first is direct cell cytotoxicity, where CD8 positive cytotoxic T cells kill targeted cells. The second is an inflammatory reaction, where effector CD4 positive T cells recognize the antigen and they release inflammation-inducing cytokines. Now, notice that I didn't mention any antibodies, like in types 1, 2, and 3. I talked about T cells, and this is why it's cell-mediated. Some examples of type 4 hypersensitivity include contact dermatitis, like from poison ivy, and graft versus host disease. There are some tests, like the PPD test for tuberculosis infection, patch testing that you can do for contact dermatitis, and the Candida skin test for T-cell immune function. Now, to remember type 4, you can remember the 4 T's: T cells, transplant rejections, TB skin tests, and touching, or contact dermatitis. Now, just as type 1 was the first and the fastest, type 4 is the fourth type and the last type, so it's delayed. So we've finally reached the end of our discussion, but let's do a quick test yourself question. Pause the video to read it on your own and think through it. A 43-year-old woman presents to her primary care physician complaining of persistent blisters that she has had now for several weeks. She reports that the blisters started on her lips and then developed on the skin and have since began to slough, resulting in open ulcers that are painful. You refer the patient to a dermatologist who performs a punch biopsy that reveals the target of the autoantibodies is desmoglein 3. Which of the following utilizes the same hypersensitivity reaction as the one this patient is experiencing? Now, remember, we talked about desmoglein earlier. It's that component of desmosomes. We've talked about acantholysis, or the separation of keratinocytes. Now, you're right if you're remembering that this is pemphigus vulgaris, and there are IgG antibodies against desmoglein, and it's a type 2 hypersensitivity reaction. So which of these choices is also a type 2 hypersensitivity reaction? Now, we just talked about nickel as contact dermatitis in type 4, and we've talked about the Arthus reaction as a type 3 hypersensitivity reaction with immune complexes. We talked about bee stings in anaphylaxis in type 1, and we talked about TB tests in type 4. So the only one left is Graves' disease, which, if you remember, has anti-TSH receptor antibodies. All right, that's all I have for you here. Please give this video a thumbs up if you liked it, and it'll give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard.